going to, I do have Stephen Twigg on the line. Steve, he's the Professor of Endocrinology and our wonderful clinical director. We're going to start the presentation now.
Thank you. So thanks for those who had the patience, and sorry about the challenges we've had here. So the organisation we're linking in with Webinar Jam, there have been a few jams, but also the jam might refer to exercise. So there's a few positives there, aren't there, as well, for people with diabetes. Now, this first webinar today is focused on the neuropathy, nerve damage that occurs quite commonly in diabetes. And deliberately, I've put as a subheading, prevent, prevent, prevent. And I think that'll become increasingly clear during this presentation. If we go on to the next slide, we have I think it looks as though, yes, I can activate that. We actually had a couple of webinar questions we were going to put up the front, but I'll just mention those then as we go through. Most people with diabetes will develop over the course of time some neuropathy clinically, and so the majority will develop it. And secondly, our focus needs to be on preventing this condition in its onset and progression, because once it's established, we're mainly trying to prevent the adverse outcomes of neuropathy. So we really need to focus in on working out how we can best manage people with diabetes to minimise this adverse outcome and to maintain quality of life. So if we look then at this slide, this condition is also known as peripheral neuropathy in diabetes. It involves typically the feet initially, down at the toes. Other than diabetic retinopathy, it could be argued it's the most common end organ complication in diabetes. And it's viewed as a metabolic toxic neuropathy. And what I mean by that is that the adverse metabolism with glucose and probably lipids are two major mechanisms which are thought to lead to this adverse outcome. And if we just consider the next slide on the right-hand side there, you might be aware that the sensory neurons are about 1 metre in length. So right down to the toes and then up into the spinal cord, the dorsal root ganglia. Those neurons, you could imagine, if their metabolic environment is not correct, then they can lose function. And they'll mainly do it most distant from where the nucleus is and the major cellular functions. And so that will normally be down in the toes, down in the feet. This condition is a leading cause of amputation. Most people with diabetes who end up needing an amputation have neuropathy or arterial disease or both. Some, of course, have a past history of ulceration and amputation, but neuropathy is normally present to some degree in people who unfortunately end up with an amputation. Also, the more common condition of Charcot-neuroarthropathy is often linked in with this condition, in the sense that people who develop that fractured dislocation condition that markedly damages the foot will always have underlying neuropathy. Thankfully, that condition only affects about 1 in 500 people with diabetes. But in contrast, this polyneuropathy very common. Now, treatment options, once it's established, we really are trying to palliate and prevent adverse outcomes of ulceration and infection, etc. We actually don't have medical interventions that can reverse the damage. However, we have good evidence that we can prevent the onset and progression of this condition. And when we look at the different subtypes as well, we'll need to consider the painful type, which can be very disabling for some people. So if we have a look at this next slide, just down in the bottom right-hand corner, I wanted to show some skin biopsies, a person without diabetes and then someone with diabetes who had neuropathy. This was published about 10 years ago by a PhD student, Lee Sorensen, in our group. and it stains the peripheral nerves after a cutaneous biopsy. So this was a research study looking at the nerve fibers. But as you can see, those with diabetes and neuropathy, there is a dropout of the nerve fibers, and they're very disorganized in the skin. And in a person with diabetes without neuropathy, their nerve fibers look like the one with no diabetes. So try and get that image in your head. These nerve fibers drop out. The next slide then is, what about the contributors then to the nerve damage in this condition? Well, to be fair, if we knew more about this, then we wouldn't have to continue to show hypotheses diagrams, as I'm showing here. And because we don't have specific interventions that can reverse the condition, even though quite a number have been studied, this remains largely a hypothesis. But I'd have to say that high glucose and also abnormal fats are thought to be the two main factors that contribute to diabetic nerve damage with peripheral neuropathy. Blood pressure is probably also a factor, so a hemodynamic factor. And then also people that are taller are much more prone to develop peripheral neuropathy. So in general, men more than women, and that's thought to be related to neuronal length under metabolic stress. The cartoon on the right tries to summarize one approach to the concept of how high glucose in the blood and then moving into cells can cause damage to neurons. And there's a number of different downstream pathways, some of which I've shown here: reactive oxygen species, mitochondrial dysfunction. In addition, it's well recognised that abnormal lipids very likely contribute, particularly in people with type 2 diabetes, but even in type 1 diabetes, to the peripheral neuropathy. And the high triglycerides and also a moiety known as diacylglycerols, DAGs, linking in also with free fatty acids, can cause damage. And on the far right hand of this cartoon, you can see as well that diabetes is a condition of insulin deficiency, and in the absence of insulin, probably the nerves don't function well, full stop. And so the lack of insulin in its own right contributes, it's thought, in this setting as well. So we've got a number of metabolic and hemodynamic factors which play into the process. Now, when we consider then what do the peripheral nerves look like, it's probably good to get into your mind also this electron microscopy image of a diabetes nerve affected with dense peripheral neuropathy, where there's loss of feeling in the feet, compared with the person who has a normal nerve, either with diabetes or without diabetes. And as you can see in these nerve fascicles, these little dark circles, for example, in the normal nerve, they're myelinated nerve fibers. In contrast, for a person that has established peripheral neuropathy, the axons, which are within the myelin sheaths, they drop out, so it's an axonal neuropathy. And then in many people with diabetes, they also have the lack of myelination. So there's loss of nerve fibers, that's an axonal condition, axons, and there's also demyelinating elements which are often present. And so we look at that image and say, yes, that can be, the situation, gross abnormalities of the nerves. But it's also the vessels supplying the nerves. And I've shown just below the cartoon that we had previously a vessel here which is largely filled up, if you like. It's a small arteriole, but it's filled up in its lumen with fibrotic change. And we think advanced glycation end products that come from high glucose and lipids and also reactive oxygen species contribute. So there are a number of concepts here. There's direct nerve toxicity and dropout. There's demyelination of the peripheral nerves. And there's also the effects of reactive oxygen species and other intermediates on damaging the vessels, the vasa nervorum, that supply the nerves. So there's a couple of subtypes of peripheral neuropathy. The one we've been mainly focusing on is that on the left, the chronic form, and its onset can often be subtle. People who develop this condition, sometimes they have no symptoms at all. Other times they have some numbness developing intermittently in the feet, and then it can progress over a period of months and years. And it really does, there is a mixture of presentations. The minority of people develop the painful type, which is more, I've put here, the acute painful type of sensory neuropathy, and that can certainly be debilitating. That appears to occur equally in women and men. Its pathogenesis is even less well understood than the chronic diabetic polyneuropathy, but is probably partly vascular based. And we find that in people who experience this condition, it occurs whilst in only a minority of people with peripheral neuropathy, that if it affects their sleep in particular, it's often associated with the depressive type syndrome and really adversely affects their quality of life. And so I'm not going to spend a lot more time on that condition other than to say chronic pain teams, experienced physicians, endocrinologists and teams are the ones who really can support the primary care in the acute painful form. And you can get mixed forms and as well. So keep in mind that some people will have the loss of feeling in the feet, some will have the painful type, and some will have both. The most common type is the chronic insensate or reduced sensation one, the one on the left. And the symptoms, though, in a person with painful neuropathy can vary. It can feel like ants crawling on the legs, knives, lightning shock effects, and burning. So sometimes even the touch of a bedsheet, that what's called allodynia, can be very distressing. We're not going to spend much more time on the painful neuropathy because it's not linked in its own right with loss of feeling in the feet, the painful form, even though it is debilitating. It's the one where there's loss of sensation in the feet, the more common one on the left, that we're going to focus more upon. So if we look at risk factors for the chronic polyneuropathy, hyperglycemia, and that's often viewed as being HbA1c, so the marker of average glycemia, particularly over a period of years, and some people refer to HbA1c years of exposure, a bit like pack years of cigarette exposure. And then there are other factors. I've already mentioned height of the individual, particularly for the foot peripheral neuropathy, which is the usual presentation, dyslipidemia, blood pressure is probably in there, and end-stage kidney failure and liver failure are linked with peripheral neuropathy as well. Now, on the little graph in the middle, I've provided the key data from one of the important studies in diabetes known as the Diabetes Control and Complications Trial. In that study, they looked at the relationship long-term over 6 years in people who'd had type 1 diabetes only for about 4 years initially, so they were relatively early in their disease course. They carefully characterised those who had and developed peripheral neuropathy. And as you can see over time, there's about a 7-fold increased risk if the HbA1c is running in the well into the double figures range compared with the targets that we'd normally have for people with type 1 and type 2 diabetes. And on the right-hand side then, the data tells us, and the DCCT was an intervention study, that we do need to try and optimise glycemic control as early as possible to help prevent the onset and progression of the polyneuropathy. And for people with type 2 diabetes in particular, but also in type 1, we focus on lipids and blood pressure, with less evidence that we can prevent the progression and onset of neuropathy, but because of the holistic approach, particularly with cardiovascular complications. So if we look at this next slide, this is a backup one from the Diabetes Control and Complications trial. And the intensively managed group had their HbA1c levels on average at about 7% for 6 years. The conventionally managed group, their HbA1cs were sitting at 9% for the same period of time. So this was a randomized control trial asking the question, does metabolic control matter? And as you can see, whether it's by the clinical neurological examination, that is the loss of sensation by the monofilament and tuning fork, or whether it's more subtle testing with nerve conduction studies and autonomic nervous system testing, both of which were research tools in this study and we don't routinely do clinically. As you can see, there's more than a 50% reduction in development of neuropathy in those individuals in the intensively managed group. Now, the average duration of diabetes at the end of this study was 10 years in people with type 1 diabetes. So you might say, oh, only 20 or 30% had the abnormality. But as the decades progress, the peripheral neuropathy in its own right does increase in amount. But this is very helpful data showing to us the importance of glucose management to help prevent the onset and progression. And I'm showing you here the progression data, but the onset data was very similar. About a 50% reduction in development and progression of peripheral neuropathy by tight glycemic control being realised and maintained. So then if we move on to what clinically then happens and how does the foot present with peripheral neuropathy? Well, people often find that they cannot feel their feet. They become spongy, and then they are prone to develop trauma, and they don't get the protective sensation, that message to their brain that there's a distress pain signal. Secondly, there can be with peripheral neuropathy and diabetes not just loss of sensation, but also weakness in the small muscles of the feet and higher up the leg. And that can result then in particularly what's known as claw toes. There can be hyperextension at the metatarsophalangeal joints, and a lot of pressure under the metatarsal heads is a characteristic finding. And then thirdly, the autonomic nervous system as well is affected often in peripheral neuropathy and neuropathy per se in diabetes. And that can result in dryness of the feet, sweat gland action is impaired, and a proneness to fissuring, and then fungal and secondary bacterial infection. And so those combination of factors are thought to contribute. And on the cartoon on the right, you might see there with the peripheral neuropathy, there are often changes in the shape of the foot and pressure under the metatarsal heads. And a characteristic site for a foot ulcer to develop is under the first metatarsophalangeal joint of the foot, if not under the hallux itself. Now, if we look at then, how do we think that the condition goes from peripheral neuropathy ultimately to a foot ulceration? Well, firstly, in peripheral neuropathy, the foot is often changed. It's not always the case, but it often will be that there's increased pressure under the metatarsal heads from the peripheral neuropathy, and the person secondarily cannot feel their feet well. We often find as well that with mechanical changes in the feet, that this what's called the windlass mechanism, that is the ability to toe off when a person is walking, is impaired. And a skilled podiatrist clinician can assess the mobility around that joint, and it's often impaired also with other complications of diabetes. Then increased pressure areas develop, and in the abnormal loading that you see there is callus under the fifth metatarsal head. The callus itself, it's known that today's callus is tomorrow's ulcer. We need it to be captured early. And I've just shown a little cartoon above with skin and then blister and blood blister. And we know that over time that the increased areas of pressure, which callus is a protective response, but with time splitting occurs between the epidermis and the dermis, and that shearing will result ultimately in hemorrhage, and then there's an ulcer there. And so under callus development, you can see there that it looks as though it's progressing to a hemorrhagic form. And if we look at the one on the right, there is certainly some hemorrhage underneath the callus there. So that's a much more advanced callus. And with debriding one, there will be an ulcer underneath. So we'd like our preventive podiatry to prevent callus formation and also to detect it early and help to manage it. Increasingly, however, the hemorrhagic callus can result then in an ulcer. And on the far right, I wanted to flag to you that there is also the scenario where a person who does not have that feeling in their feet can develop a sudden onset foot ulceration. They don't necessarily have to go through the whole callus development. For example, on the far right at the bottom is a burn from a cold evening and being too close to a heater. And the one next to that is from tight-fitting footwear, new shoes, tight-fitting shoes. Someone's going for a fashion statement, and that's not unusual. About half the cases of new onset foot ulcers in people, especially with peripheral neuropathy, is related to their new onset use of footwear. And then in the top right is a penetrating injury in a person that again, may not have had much callus and chronic change there, but they cannot feel their feet well, and unfortunately they haven't protected their feet. So there are a number of pathways by which foot ulceration can develop in people with polyneuropathy. So when we come to considering, does someone with diabetes have polyneuropathy, you can get feet that look like the one on the left. They look normal. So the first thing is, as a clinician, look at the patient's feet and they might look like the one in the middle. There might be even toes missing. There might even be new onset foot ulcers, but they might have characteristic deformities of diabetic foot disease with peripheral neuropathy, or they might have some autonomic changes as shown on the far right. But we need to look at our patient's feet. We look carefully for corns and calluses and any deformities, bony and skin, soft tissue. But as you know, unfortunately, as clinicians, we often neglect looking at the feet in the first place. Now, it's one thing to have a good look at the feet and inspect. After that, we need to more formally examine them to see if there is loss of sensation. So the foot examination really does involve neurologically tests of vibration and also tests for light touch sensation. Now, I focused here particularly on the monofilament, the Simmons-Weinstein monofilament. It's a specific one. It has a specific gauge and weight. And this should be applied under the 1st and 5th metatarsal phalangeal joints and also under the hallux. They're the 3 sites to test. If a person doesn't have much callus there, they should be able to feel each of those sites. And it's just that pressure applied and held with the, here we have the perspex rod being held by the individual. And on each foot, they should be able to feel each of those 3 sites. Now, the vibration sensation can be tested with a regular tuning fork. Our diabetes centre and others use a thing called a biothesiometer, which is a glorified tuning fork, but essentially whether the patient can feel the vibration or not. There are some other tests, and you will hear about in this webinar series some other more sophisticated ways. And then there are some, what you might argue, are more practical ways. And there is the Ipswich touch test, where basically a person who has normal sensation themselves as the clinician touches the patient's 1st and then 3rd and then 5th toes, and then also just over the dorsum of the hallux. And they just spend a couple of seconds at each side and ask the person if they can feel the touch. And if it's just light touch, if the person can feel every site, that's fine. If they can't feel it at least 2 or more sites, then that's abnormal. But that touch test, I think, is increasingly validated internationally and nationally. And I think, however, that the tool which at this stage that we should mainly plan to use most is the Simmons-Weinstein monofilament and also checking for vibration. The first abnormalities clinically often to become noticeable in people with peripheral neuropathy are loss of ankle reflex and loss of vibration sensation. In general, the monofilament will only be lost after those 2 are lost, but it is the most predictive test for foot ulceration. So if you can only do one, I do the monofilament test. So then if we move on to just considering for a moment, if someone has peripheral neuropathy and diabetes, is it always due to diabetes? And the answer is there are many causes of peripheral neuropathy. Diabetes is definitely in the top 4. So I teach my medical students over the years, and I didn't make up this acronym, but it's probably why partly it's stuck. It preceded me by decades, but DANG therapist. On the left-hand side, diabetes, alcohol, nutritional and Guillain-Barré syndrome and autoimmune disease. There's a chronic form of that. They would account for 90% plus of causes of peripheral neuropathy. On the right-hand side is the acronym therapist, and there are a lot of other conditions which can cause peripheral neuropathy. So how do we work it out if diabetes is the condition causing the peripheral neuropathy? To cut a long story short, in a person with diabetes mellitus, if it's involving both feet, particularly the toes on both feet, there's a numbness, a feeling of loss of sensation there. It's progressive over months to years and quite symmetric. That would be absolutely characteristic as the years progress in a person with diabetes. Now, the polyneuropathy can be present at diagnosis in type 2. Some people, their diagnosis is delayed and they will have the polyneuropathy, but normally people will have had diabetes for 5, 10 plus years. If the condition is asymmetric, if it's got a major muscle involvement to it, if it's extending up the legs rapidly over weeks to months, certainly days is not characteristic of diabetes, but diabetes is a much slower time frame. If it's involving the hands, that would be very unusual for diabetes unless already the legs are involved up to the knees. So sometimes we will check for other conditions, make sure that the patient, for example, is not thyrotoxic, make sure they don't have a myeloma or other malignancy. So we try and do a holistic assessment of the patient, but in most cases with diabetes, polyneuropathy is common and the presentation is as I've described to you. If we go on to the next slide, this is an important concept, I believe, as well, and that is if someone has peripheral neuropathy, the number needed to treat is a lot smaller to prevent foot ulcer. So in our diabetes centre years ago, the head of our centre at the time, Professor Dennis Yu, he looked at the risk factors related to development of a foot ulcer. And in roughly 300 people, if they don't have neuropathy, and let's presume your intervention, whatever you're doing, is going to help prevent an ulcer 50% of the time or so, then you've got to treat 266 people. But if they do have neuropathy, especially if they cannot feel the monofilament, you only need to manage 25 people. And if your intervention is successful about half the time, you'll prevent 1 foot ulcer per year. If they've had a history of previous ulceration or amputation with dense neuropathy, then you only need to treat 8 to prevent 1 new onset ulcer per year. The challenge is there, sometimes the feet are very deformed, sometimes there are behavioural issues in those individuals, which would be hard to reduce the risk by 50%. But as you can see, assessing for presence of peripheral neuropathy is very important. You can target the individuals that need more intensive follow-up, education, and overall management. So this particular slide is a major condensation of some of the international working group and the diabetic foot guidelines. I did have some insignias on an earlier slide recognising the National Association for Diabetes Centres and Diabetic Foot Australia and the collaborative efforts that are being made there in Australia in foot disease and informing the ADS and linking in with the NDSS and FootForward initiative. At an international level, DFA in particular is closely linked in with this international working group. And there are new guidelines which are increasingly being adapted to Australian conditions, so watch this space. But in the prevention chapter in these guidelines, I just wanted to mention these key points. Examine people with diabetes at least annually. If they are at low risk, then they need at least the annual examination. If they're deemed to be at high risk of foot ulceration, for example, with polyneuropathy or arterial disease or history of ulcer or amputation, then the screening needs to occur more frequently, and usually podiatry would be involved in foot care maintenance. If there is a person deemed to be at high risk, then we need to educate them about protecting their feet indoors and outdoors, and we also need to encourage them to inspect their feet on a regular daily basis, to wash their feet and moisturise their feet, to report promptly if they develop new onset foot ulceration. And in addition to that, maintenance podiatry is very important. And we believe also, sorry for the typo there, but prompt referral if a new onset ulcer develops to an established high-risk foot service that has the multidisciplinary skill set to help an ulcer to be healed, hopefully, in a timely manner is critically important. So if we move on to the next slide, this is a simplistic stratification concept. And in subsequent webinars through the FootForward initiative, you're going to see a more nuanced approach, a more helpful approach. But in general, if people have low risk, they don't have neuropathy, PAD, and other risk factors, then their intensity of follow-up can be less. If they have a new onset foot ulcer, they should go to the high-risk foot service pronto. In between, if they're deemed to be at high risk, then I've mentioned already the working group guidelines, education, self-care, regular podiatric maintenance, behavioural changes, and preferably podiatry being involved. And so appropriate footwear. Orthotics have a role. Education, healthy feet are happy feet. Some of the education can occur in groups, sadly in a COVID-19 era, a bit more IT based. And then also we have treatment of callus. That callus there was a bit late in the top right. That will have an underlying ulcer rather than earlier treated callus. So in summary then, the key points in this particular condition are that asymptomatic neuropathy and minimally symptomatic is very common in people with diabetes. Patients are not often aware of any problem and or they neglect the symptoms. The foot complications are a common sequelae, and as we know in their lifetime in people with diabetes, about 1 in 5 will develop a foot ulcer, and usually they will have underlying peripheral neuropathy. We need to examine the feet of our patients on an annual basis as a minimum and to work out what risk they're at with respect to foot complications, and then what degree of intervention they need and follow-up to educate them, preventive maintenance on their feet, and to ensure that if they develop a new onset foot ulcer, that they are seen in appropriate services in a timely manner. And the last point I'd say again, even in the COVID-19 era, there's a lot we can do to educate our patients in their self-care to help prevent neuropathy onset and progression. And also we continue to have high-risk foot services accessible and podiatrists who are able to help out with our patients. I think subsequently in further webinars, there'll be more COVID-19 information, but I'll finish off there. Thanks, Georgina, and thanks again to colleagues who had the patience to hang on in there with some of the technical challenges that we've had. And I'd strongly encourage you in subsequent FootForward presentations. I think they'll be a bit slicker from the IT and maybe even also from the presenter. But I'll stop there. There may be questions, Georgie, still that we can field in the time available.
Thank you, Prof. Twigg. That was great, especially with all the adversity. I suppose I'll get you to answer the 2 poll questions. And then everyone can see what their answer was and how close they were. So the first one was, what percentage of your patients with diabetes will develop clinical polyneuropathy?
Yes, well, as I mentioned in passing on one of the slides, said at least 50%. And you saw from the DCCT that it was more around the approaching 20%, but they only had a 10-year duration of diabetes. So it is a condition that will affect the majority of people with diabetes as they progress, if you like, across the years. And so there's an age-related neuropathy which sort of links in as well. But I would say the 40 to 60% is generally correct. If you link in with the age-related process, you might argue it's even approaching 80%. But the 40 to 60%, I'd pay that with top marks, but I might accept a little bit of wiggle room. Depends on patient series.
So for the second one, what's the most correct answer about clinical diabetic polyneuropathy?
Yes. Well, as we know, we can help prevent the onset and progression of peripheral neuropathy in diabetes. Unfortunately, at this stage, we don't have clear evidence-based medicines that can reverse the peripheral neuropathy. And once someone has established peripheral neuropathy, it's helping principally to prevent amputation and progressive, other lesions like callus and other problems leading to ulceration and then potentially amputation. So we can help prevent the onset and progression. We don't have regular clinical treatments for the peripheral neuropathy to either reverse it or to medically manage it. So just coming back to our webinar questions there, Georgie, I think probably the way that I write these questions would be B. We don't want everyone choosing C all the time. And so hopefully that's helped our audience appreciate the importance of getting in early, preventing diabetes, preventing peripheral neuropathy onset in those with diabetes, and preventing its progression.
We have 4 questions or 5 questions. We'll start with, and I might broadcast them so you can actually see them. So this is the first one from Hardashan. So I'll just broadcast it if everyone can see it. So feet checkup by GP only is good enough, or do you need to see a podiatrist also once a year?
Any health professional who's been trained in foot assessment can undertake that process. And so the GP is perfectly positioned to undertake the foot assessment in a person with diabetes. So thank you for the question. And it's typically been involved in the annual complication screening with the annual cycle of care at a primary care level. I know that some of these processes are changing in their remuneration item numbers and even their descriptors. But definitely in terms of at least annually, initially to stratify risk, taking those patient shoes off, taking the history, carefully inspecting the feet, and assessing with the monofilament and vibration. They're critically important functions to undertake. Primary care, general practitioner, practice nurse, perfectly positioned to undertake those assessments. Thank you.
And I'd probably add, I think then your assessment then changes. So once the person has either they're at low risk, moderate or high risk, their rescreening then becomes more regular. And that can be done also by anyone within the healthcare team who's been trained. So most people in diabetes, or it's just getting to that regular take your socks off and check process. That's the podiatrist speaking. So our next question, is there a way to capture people with diabetes who do poorly when they develop peripheral neuropathy? There seems to be some people who do really poorly with diabetes, even if they live well.
Yeah, thank you. Diabetes is a syndrome, isn't it? A collection of symptoms and signs, and some people do seem to progress much more rapidly into complications. And one group that we identified at our hospital is young onset type 2, unfortunately, where we see that that aggressive, often diabetes and complications coming out of that. Yeah, it really does require persistence, doesn't it? And our variety of different healthcare services, we do often find that, unfortunately, people who have this aggressive progression, that they will often present initially with the foot ulcer, hopefully prior to an amputation, but an infected foot ulcer is not unusual. Yeah, they're the ones that can slip through the gaps, and we try really hard to ensure continuity of care, integrated care back out into the community. And as you know, it will depend upon how your healthcare systems are set up, to what extent you might be able to flag high-risk individuals and alert systems to remind you if they haven't appeared for their regular follow-up checks, and have they followed through also with their podiatry referral. So oftentimes it does get back to referral systems to try and minimise falling between the gaps. I would say many local health districts now and healthcare services, we are helping to close those gaps in continuity of care. Our diabetes centre, high risk foot service, from a foot care point of view, was closely linked in with community services and step down, if you like, services. And from a primary care point of view as well, we work very hard at closing that loop. After saying that, you know, it is the case that not only with the aggressive complications, we find there are often behavioural issues, very significant ones. And as we know, some of our patients are less prone to follow through with the behavioural advice. And this is where a person can get into real trouble with respect to foot ulceration. Once a person develops one foot ulcer, they'll usually develop at least three, and then they're on that slippery slope. So I don't have any magic solutions other than saying that systems approaches and flagging these high-risk individuals may help your process. I mean, any further comments from yourself there, Georgie, about that situation, people with aggressive disease and following them up?
Look, I think it's what you said. It's that support structure you can put around people is probably, and, you know, getting as much integrated care as possible. I think it is really hard, especially because we don't have a cure for peripheral neuropathy yet, or polyneuropathy. So
there are some dedicated multidisciplinary clinics. I mentioned young onset type 2, for example. Some centres around Australia are focusing on that group. Type 1 diabetes. Sometimes, you know, from a specialist point of view, we're doing our best to share the care. So in my experience, so look, we'll work together on that. Thank you.
All right, give me a couple of seconds. I'll just go. So we have this question here. So what are your views on acupuncture dry needling for people with peripheral neuropathy? There are some emerging studies around acupuncture helping with hot and cold sensation in the feet. Thoughts?
Yeah, thank you. Look, it's an interesting one. And as far as I'll refer to alternative therapies go, and people that practice acupuncture would say that it's probably, rather than alternative, it's a complementary or established therapy now. I think there's good concepts behind it. The Melzack-Moore gate control theory of pain and the role of acupuncture in terms of pain relief. I believe at this stage, and if we look at the International Working Group guidelines and the Australian ones which are available, that we don't have the level of evidence that we would like about the established role of acupuncture, for example, in treating the reduced sensation peripheral neuropathy. With the painful type, we often look at multiple modalities, and I didn't discuss the series of medicines that are often used in combination, as well as mechanical methods, for example, transcutaneous electrical nerve stimulation machines. Acupuncture is certainly on that list. Then there are psychological approaches, often treatment of mood disorder, and also other processes like meditation and stress relief. I again believe that the level of evidence that acupuncture, whether it be needling or laser, can routinely help painful peripheral neuropathy isn't as high as I think the medication interventions are for palliation, for symptomatic relief of painful neuropathy. However, watch this space. I mean, it's a difficult area because by definition, it's a symptom that's being treated. How are you going to sham the control group is always a challenge when you're doing a randomized controlled trial. And we know there's a fair bit of noise around these subjective scales that are reported. So would I view it as being an option in a person with painful neuropathy? Yes, particularly if they were very disabled by their pain. Would I have some background concern if someone had insensate neuropathy? Yes, as well. I'm not a great fan of the skin being punctured, particularly in the feet of a person who can't feel their feet. So I think if someone had a pure painful neuropathy, I view it as a complementary method that could be trialled, not at the same level of evidence as a number of medications and combinations. If someone had the loss of feeling in the feet, I don't believe the evidence base is there, and I'd be concerned about firstly not doing any harm.
Thank you. I'll move on to our next question. Previously, elevated HbA1c was considered to impair wound healing. Some newer theories suggest it's irrelevant to wound healing. What are your thoughts?
Yeah, nice questions by everyone. Nice diversity. In December last year, I spoke in Perth on this specific topic. And I believe at this stage, whilst glucose management is very important to help prevent neuropathy and also peripheral arterial disease, we don't have the evidence that acutely intervening with glucose will help a wound to heal. And so at this point in time, in the absence of good quality evidence, I think we just have to say, well, we wouldn't have that as a high priority item in someone who develops a new onset foot ulcer. Of course, after the careful initial assessment, the ulcers are often infected. They need antibiotics. The blood supply is not optimal. They need assessment for that and often revascularization. We need to minimize pressure at the site of the ulcer and remove dead tissue and slough, and so debridement and minimizing pressure by offloading, and then dressings, of course, of the ulcer, very important. So that requires the teamwork-based approach, the issues of addressing infection, trying to minimize the pressure, creating a more acute rather than chronic wound, and also vascularization. So it's an interdisciplinary team-based approach. That's why the high-risk foot services have good evidence for their outcomes. In contrast, a knee-jerk reaction is to say, let's get the glucose levels improved. We need a randomized controlled trial, a well-done one, to answer that question. But I'll just say some observational data internationally from Europe shows with those people with lower A1Cs actually have a higher mortality rate in people with established foot ulceration. You might be aware we need to be very careful in people. We don't drive their glucose levels down too hard if they might have underlying macrovascular disease. There have been a number of studies which have taught us that. So I think in patients that I see with established foot disease in their service, late stage neuropathy, we try and get the A1C down if we can below 8%. In general, we don't target the generic 7%, and we just try and get the glucose level to the point where they're, safe They're not having hyperglycemic symptoms, not having incontinence of urine and macerating their ulcer that way, but at least just trying to help them keep asymptomatic of hyper or hypoglycemia in the setting of a foot ulcer. So it's an important topic, and it's one that needs to be addressed by higher level evidence. And at this stage, though, don't rush in and think, oh, that needs to be my top priority in person with the foot ulcer. Your top priority is to find the high-risk foot service that can promptly help manage that patient for you.
Thank you. We have one last question, and it sort of fits in with the topical treatment for neuropathy. So I think it's thinking back to the old, I think, capsaicin cream and those sorts of things. Do you think there's a role for that in treating neuropathic pain?
Yeah, thank you. So again, I didn't focus much on that. There is some evidence base for topical therapies. Yes, capsaicin, also phenalgon type creams. I often find, what I've found often with patients is that those treatments initially can exacerbate the neuropathy for a period of time, sometimes days or weeks, before they possibly deaden the nerves. Secondly, they often need to be applied very extensively to have benefit. So I have to say, in my own practice, I tend to focus more on the oral agents which are approved under their PBS, pregabalin, for example. Duloxetine's more for depression, but it's approved under the TGA for painful neuropathy. And patients who really are getting poor quality sleep, we know that opioids specifically can help with this pain problem, and they're a good second-line option. So a lot of my patients still are on small amounts of oxycodone in the evening, or some of them even on a buprenorphine and Norspan type patch, particularly if they need that addition after we've optimized their other oral agents that I've mentioned already, a couple of those. Amitriptyline, a good one, it's tried and true. It's just the adverse effects, the anticholinergic effects that tend to relegate it a bit for me. So I think, yes, the topical treatments in people with painful neuropathy to palliate that symptom, they can be trialed. It's, I'd have to say, my experience in recent years has been using those less. However, I do know some colleagues that utilise them much more often to try and help with local symptoms.
Thank you.
So that's helpful. We didn't have that sort of key extra slide on the painful neuropathy and management there, Georgie, because we're particularly here focused on maintaining toes and feet, preventing ulcers, and it's the insensate, the loss of protective sensation neuropathy, where our major focus has been today. But hopefully our attendees, it's helped them with a few of the images there, the dropout of the nerves, the loss of the axons, and that we can have a major positive effect in our patients by getting in, helping with that glycemic control early and maintaining glycemic control. And then if they have the dense neuropathy, preventing foot ulceration through appropriate preventive care.
Thank you, Steve. And I suppose I could follow up because we've got a few comments just going forward. So part of the FootForward program is to sort of improve assessment or just screening for people with diabetes. And that's also for consumers to be a little bit more engaged. And so in July, we'll be launching an e-learning module, which will have a lot of information about foot assessment that you know, with breakout modules with peripheral arterial disease, polyneuropathy, which is Steve is covering, and foot ulcers and management and those sorts of things. So we'll be going into a little bit more detail, and the webinars will sort of reinforce that and give you a bit of a taster. So I think this is great in that if we can just keep this momentum going. So I think that's my very clumsy ending, because everyone's saying great things, but keep your eyes out because there are so many parts of screening that are so important. So peripheral arterial disease, and that screening is one of our follow-up presentations, just to answer a few of the questions that have come through. Have you got any final points, Steve?
No, except to say I'd encourage those who come onto this webinar, please view it as a total package. Definitely the focus here was on peripheral neuropathy in diabetes, and even the assessment part, as Georgie says, will be much more systematic in the appropriate follow-up webinars in terms of holistic assessment of the foot of a person with diabetes. But we just felt that the polyneuropathy is often neglected. We needed to put it in proper context for our clinicians, and then we can move forward and start to look at the arterial disease and the combinations of factors that we need to undertake in our assessments and then management for a person with diabetes.
And we're also going to hopefully join up. So
we look forward to further installments, Georgie, and hopefully we'll have a suite of webinars that people can click onto in the future.
And addressing some of the COVID-19 challenges that we are.
Goodbye.
Goodbye.
Stay well.
Thank you. Thank you, everyone. Any questions, please ask.